name is Dr. Ron Boeding. I've started a series of brief videos that I'm doing to try and help patients have better access to me and also better access to the discussions and kind of recommendations I usually have that I might talk with them about in clinic visits or at the time of a procedure. And of course, lots of questions come from those visits because people will say things like, gosh, he told me about this procedure, but I just don't remember the details, or I really wanted to share that with my family. I wanted to tell my spouse because they need to know, and so we can make the best decision. And I thought that if I had a video link that I could share quickly, that would help speed up the process and kind of get some good standard information out, at least as far as how I practice. So this video link is meant to be helpful for all those common questions. So I'll start by talking about a very common procedure, which is called a medial branch block. And this procedure is done in many locations: the neck, the middle back, the thoracic spine, and the low back. And it's even done, we even do these kind of diagnostic blocks in other joints, but more on that later. The medial branch block is the injection that is a nerve block, and it's a nerve block to get the knuckle, if you will, the joint, the facet joint in the neck or the low back or the middle back, to be numb. So we want to numb the knuckle so that the person can later tell us, gosh, that's where the pain was coming from. So if I go into the low back with my needle and I inject the knuckle, just numbing, local anesthetic only, no steroid, and I get the person 10 minutes later off the table, they're twisting, they're bending, they're looking, they're turning their head, and they tell me, wow, that pain is gone. That pain that was there is gone. Then I feel really confident that the source of the pain was the knuckle. And of course, as many things are, that's about all we're doing. That's the point of the thing, but insurance had to make it a little more complicated. So they require, and this is Medicare rules, so I'm speaking generally about Medicare rules, but they require that we have 2 successful test blocks. So let's say we're doing the neck, and we'll go into the neck joints that we've picked based on your MRI results, and we'll say, I wanted to numb these knuckles, and we have to have successful, good results, 80% relief for at least two times. So it can be quite challenging because I'll have a patient and I'm seeing lots of arthritis in every level, and I'm saying, gosh, where you're telling me I think I should do the lower half, say, and we'll do the lower half knuckles, the facet joints, and then after the words, the person will tell me, it's pretty good, it's maybe 50% better, but I think there's a little bit of pain a little higher. I think you were too low. And then I can say, okay, let me go ahead and do a test block again next time, and I'll numb sort of the higher knuckles. I'll overlap a little bit. And then the next procedure, let's say, hopefully is really effective, 80% effective. And at that point, we feel confident. But keep in mind, I had to have 2 successful blocks. So now I have to do a second block on that set of new levels, which was already the second block. So now I'm doing a third block, and that is all about just finalizing, confirming that the levels are correct. And after the levels are done and they're correct, then we can proceed to the radiofrequency ablation procedure, which is often called a denervation or a burn. I like to call it the burn. So when we do a nerve burning procedure, we're going in with a needle again, and the needle is getting very close to that knuckle and getting right to the nerve that serves the knuckle, and I'm cutting the nerve. I'm cauterizing it. I'm cutting it with heat on the tip of the needle, and that will allow the person to have long-term relief, a year, more than a year, 18 months, up to 2 years often I've seen. So when we have the burn done, another caveat here that's worth talking about is that we'll only burn one side at a time, and that's a few reasons. There's insurance reasons, there's also just medical reasons, safety reasons. We may well have done this test block awake without sedation, and see my sedation video if you have questions about sedation, because there's always a lot of questions there. And so we did the test block, 2 test blocks at least, and we finally are ready to do the burning procedure. And now we're going to be sedating you for that because it's a lot more uncomfortable, and it takes longer too. Each level I'll be burning each nerve for 90 seconds, so I'll have quite a few minutes tied up in burning those nerves. And with sedation, it's always safest to do it for the least amount of time. And we can get away with sedating someone who's pretty unhealthy, a lot of medical problems, heart disease and lung disease, and not healthy. But 5 minutes of sedation is still very safe, and that helps them get through a procedure that otherwise would have been very painful. And if the procedure takes me 5 or 10 minutes to do one side, then fine. But to do it for 20 minutes, the other side, is asking for a lot more, like an exponential increase in the amount of side effects or complication risk. So, where at all possible, we want to do them side by side, one at a time. There's another specific reason to do it one side at a time in terms of the low back, and that is that when I'm numbing up the low back, I could well numb up the nerves that go down the leg too. And one numb leg is okay. You can get home, you can limp home, you can have a friend's family member's arm, shoulder, and you can get to your house. And the numbing medicine will wear off in a few hours, and then you'll be fine and safe. But 2 numb legs and you're not going anywhere fast. So that's a reason for the low back. The neck, the reason to do one side at a time, if we needed another reason, is that the sense of proprioception, the ability to tell where your body is in space, is provided by the joints, and the nerves that serve the joints that we're cutting tell us if we've turned our head. Well, there's other things that tell us that we turned our head. For example, the inner ear, the vestibular system, it will also tell us if I close my eyes, I can still tell that I have turned my head. And the eyes, of course, the vision, that's also how we tell. So we have 3 judges, we actually have 6 judges, but 1 eye each side, 1 neck each side, and 1 ear each side. So those judges will tell us, hey, I'm turning my head. And if everyone agrees, then we all agree, all the judges agree. But if one of the judges or 2 of the judges don't agree, and they say, no, we're not turning our head, we didn't turn our head, I don't know what you're talking about, that person's gonna feel dizzy. Of course, the test blocks, we do both sides, and people do routinely report dizziness, and it's no fun, but it's part of the process to get there. Now, I don't mind someone being dizzy for an hour or 2, but if they had to be dizzy for several weeks because we did both sides at the same time, that's a deal breaker. So just routinely, we do the medial branch blocks, and then we do the burns afterwards, the radiofrequency ablations, the RFA. And another caveat that's certainly worth talking about, because it is very frustrating, and I'm so frustrated by it too, insurance has another fun rule, Medicare again. Not all insurances require this, so if you have a different insurance plan, maybe it's less, but they require 2 weeks between the burn, so between the test blocks and the burn. So test block number 1, 2 weeks later, test block number 2, 2 weeks later, burn number 1 on one side, and 2 weeks later, finally, burn on the other side. So you're signing up for 2 months of treatment before you're done. And that's just not what anybody was expecting. They come in and they say, I've had this neck pain and I need this treated, and you're the place and I've heard good things, so I want it treated too. And then I tell them this spiel, and of course they're pretty disappointed, and there's not much we can do about it, I'd say. So there was a time, I'm old enough, I've been practicing long enough for almost 15 years here, that there was a time when we could do the test blocks and we could do the burn the very next day with 1 successful test block. So things have changed, and the ratcheting up of requirements has happened. So just want to get out in front of that. And of course, the medial branch block, I think, is a very helpful tool. It's even helpful if it's not effective. So if somebody was getting their low back done, and afterwards they say, doc, you really missed it. I think that the pain is lower. And of course, I've done the lowest joints of the low back. So if the pain is lower, then I've got some decisions to make. Maybe I need to work on the SI joint. Maybe I need to look harder at the hip. Maybe I need to look harder at something else. So, and there are so many things. So even I tell people this a lot, even a failed medial branch block is still valuable. It's still diagnostic. So the value of doing test blocks is useful. And that hopefully will clear up some common questions, some common misunderstandings and frustrations. And I hope that just brings it full circle so we can have more time to talk about things that are important to you at the visit next time I see you. And I look forward to seeing you soon. Thanks for watching, and check out the next videos here for other related topics.